advance operator for the GES Education Conference call.
Yes,
Please
ma'am.
make sure your microphones are placed in the off position. Please do not place your phone hold in the same place music throughout the call. Is the moderator or alternate moderator online, please?
Yes, the moderator is here.
Thank you, ma'am. At this time, we have 70 participants online. Would you like to begin?
How many?
70 participants.
Excellent. I think we're ready to go.
Thank you. Again, please make sure your microphones are placed in the off position. I'm hearing a lot of noise throughout the call. Thank you, ma'am. You may begin.
Thank you. Good afternoon, everyone. If you would please take your microphones off. The only two phones that should have microphones on will be Dr. Wittenberg-Lyles and Dr. Sanchez-Reilly and myself. So if everyone else would mute their phones, that would be good. That way you'll be able to hear us. Good afternoon and welcome to the ongoing Geriatric audio teleconference series. I'm Michele Saunders. I'm Acting Director of the San Antonio GREC, as well as Associate Director for Education and Evaluation. This is the 20th audio conference in this series being organized by the VA Employee Education System, and we're proud to be part of this excellent educational opportunity. Today's speakers are Dr. Sanchez-Reilly and Elaine Wittenberg-Lyles, and I'll give you a brief intro on both of them. Dr. Sanchez-Reilly is an assistant professor of geriatrics and palliative care at the GREC at the South Texas Veterans Healthcare System and at the University of Texas Health Science Center at San Antonio, our affiliate. She has been in San Antonio since 2004 and did her Geriatrics and Palliative Care Fellowship training at Mount Sinai School of Medicine in New York. She is director of the Combined Geriatrics and Palliative Care Consultation Service at the South Texas Veterans Healthcare System. She is the Palliative Care Interprofessional Fellowship Program Director at the University of Texas Health Science Center at San Antonio and also directs the MSTAR program for medical students in aging research funded by the National Institute of Aging and the American Federation for Aging Research. She is currently a Geriatric Academic Career Award recipient from the Bureau of Health Professions of the Health Resources and Services Administration. She has VA research funding to look at the effectiveness of the consultation service and is the leader of Palliative Care on the Road, a unique program to educate providers in Temple, Dallas, and other providers throughout Vision 17 to further improve their delivery of palliative care. She's an author of several articles, specifically in end-of-life communication, and recently, with Dr. Wittenberg, who is our co-speaker today, she published a book entitled Communication is Comfort, Multiple Voices in Palliative Care. Dr. Elaine Wittenberg-Lyles holds a PhD in communication and is currently an assistant professor at the University of North Texas. Her research focuses on interdisciplinary communication among hospice and palliative care teams. Recently, she and Dr. Sanchez-Reilly co-authored the book that I just described, and it details the complexities of communication in end-of-life care. This presentation is expected to last about 40 minutes. Please hold your questions to the end, and we have allowed 10 minutes at the end for questions. You can access your PowerPoint presentation from the EES Catalog website. If you don't have that website, I will give it to you. It is http://vaWW.sites, spelled sites.lrn.va.gov/VA catalog, and that's VACATALOG/CU_detail, DETAIL, .ASP, ? ID = 24234. And again, please mute your phones. That means to remove your mic unless you are Dr. Elaine Wittenberg-Lyles. Okay. The San Antonio GREC was established in 1988 and has an academic affiliation with the University of Texas Health Science Center at San Antonio. Some of the primary research areas of the GREC are metabolism and endocrinology, nutrition, and oral health dentistry. Much of our clinical research involves metabolic diseases, cognitive and sensory impairment, and also oral health dentistry. Our health services research includes functional status and ethnic status, palliative care, healthcare utilization, and quality assessment. In the event that you get disconnected, call the Vance operator at 304-262-7600. We will rebroadcast this call on April 25th, 2008, 11 a.m. Eastern Time, the same dial-in number you dialed, the 1-800 number. I'd also like to remind listeners of the upcoming GREC geriatric audio conferences on May 29th at 3 p.m. Eastern. Puget Sound GREC will present evaluation and treatment of hypogonadism in older men. On June 26th at 3 p.m. Eastern, the Tennessee Valley GREC will present delirium recognition, management, and long-term care deficits. On July 31st at 3 p.m. Eastern, the Little Rock GREC will present exercise and muscle mass. Finally, on August 28th at 3 p.m. Eastern, the St. Louis GREC will present frailty. Please remember that to receive continuing education credit, VA personnel should complete their Scantron evaluation sheets and turn them in to their local EES to get CE credit. This must be done within 2 weeks from today. Thank you very much. Please mute your microphone. And now for Drs. Sandra Sanchez-Reilly and Elaine Wittenberg-Lyles.
Good afternoon, everyone. My name is Sandra Sanchez-Reilly, and I am going to be starting the presentation. I am going to be saying next every time I'm turning the slides, and I hope you enjoy this presentation. I'm also going to be playing some tapes here from different learners that we have and their opinions about end-of-life communication. So you're going to be listening to that throughout the presentation. So we're going to be talking today about end-of-life communication from interdisciplinary perspectives. Next slide. We are Sandra Sanchez-Reilly, Elaine Wittenberg-Lyles are the speakers, and you just heard Dr. Michele Saunders, whose title should be DMD, MPH, rather than MD, as you may have it on your slide presentation. Next slide. Our main objectives are to present an overview of several innovative educational methods currently used in end-of-life care communication training, meaning we're going to focus on education and communication. And the second objective is to acknowledge the importance of interdisciplinary team approach in the end-of-life care and training. In other words, we're going to be focusing on education and communication and education and interdisciplinary and communication. Next slide. I guess we will start from the very beginning, and we are going to be defining palliative care, end-of-life care, interdisciplinary, and the concept of a lived body. And we are going to focus on palliative care and end-of-life care to begin with. This is the next slide, please. You should be on the graphic that says the cure care model, the old system. This graphic illustrates what we used to think about, few years ago, if you will. So if you take the beginning of the arrow on your left hand side and you take one of your patients, Mr. X, and Mr. X was diagnosed with colon cancer, and as the time goes by and Mr. X's curative options are less and less, one day the provider says to Mr. X, sorry, there's nothing I can do, goodbye. And then Mr. X goes into palliative hospice care, and eventually Mr. X dies. If you think about this model, there is a big component of lack of communication and abandonment on this particular patient care. So if we go to next slide and we can illustrate probably a better approach, you can see that at the beginning of the figure on the left hand side of your slide, you should be on palliative care's place in the course of illness slide. And you take the same Mr. X and you go from the beginning of the graphic towards the end. At the same time that Mr. X is diagnosed with colon cancer, we introduce palliative care, which is a much more comprehensive care to his serious illness. And so curative options are there, but palliative care gets introduced at the same time. And as the time goes by and Mr. X has less and less curative options, palliative care has already been introduced until the time in which Medicare hospice benefit will come and eventually Mr. X will pass away. Now if you compare the approaches from the previous slide and the approaches from this slide, you can pretty much tell that is the best approach is the second one, because Mr. X never felt abandoned. Next slide. I'm going to remind the audience to please turn off your microphones because there is some noise on the line. Thank you. We're going to talk about the next slide, which is an oval figure that says palliative care. Palliative care, just for your definition, is an interdisciplinary care that includes modern medicine and end-of-life care. So palliative care is very inclusive, and as you can see on this figure, it is not only for terminally ill people, but also for chronically ill people with symptoms. Our main objective is to relieve suffering, and it is an interdisciplinary approach. We're going to the next slide. It should say general definitions, and now we're also going to talk about interdisciplinary and what interdisciplinary means. Dr. Wittenberg will be doing that. Dr. Wittenberg? Okay.
At the top of the slide, it should say interdisciplinary teams. And this is to cover that palliative care and hospice are delivered through an interdisciplinary team format, which is typically led by a medical director and includes the physician, nurse, social worker, chaplain, and more commonly now, a palliative care psychologist. The idea behind this is that each team member brings together or brings in a special expertise, and in this manner, a holistic plan of care can be developed for the patient. Next slide, please. The concept of the patient's lived body is what this holistic approach is aimed at, and that is that the team facilitates care by communicating about the psychological and the social aspects of dying. A common approach called the biopsychosocial approach. It combines the biological expertise, the psychological expertise, and the social expertise of the group so that comprehensive pain management and a comprehensive approach to care is achieved through an interdisciplinary staff. But this can only be achieved through adequate interdisciplinary collaboration and communication. Next slide, please. I'm now going to turn it over to Dr. Sanchez-Reilly again, who's going to talk about where we're at in terms of education and end-of-life care and communication.
Thank you. And I'm going to ask you to go to the next slide. It should say at the top, goals of education. And the main goals of education are to increase knowledge and expertise, to improve and address communication skills, and to refer to interdisciplinary team awareness. And this is a big concept nowadays, and as you all can appreciate. So we're going to talk about increased knowledge and expertise. And I'm going to give you some statistics. Some of them actually may look pretty old, but they do reflect what we have today. We know for a fact that about 74% of residencies, when we train physicians in the United States, offer no training in end-of-life care. The numbers continue to impress me because 83% of those residencies offer no hospice rotation or no hospice exposure for the medical residents. 41% of medical students never witness an attending talking about with a dying patient or his or her family, and 35% never discuss the care of a dying patient with a teaching attending. So that sounds really interesting to me. Next slide. We also have good news. Palliative care education is improving. The LCME, which is the organization that regulates medical school curriculums in the United States, had stated the following in their requirements. Clinical instruction must include important aspects of end-of-life care. Also, in residency, the ACGME, which is the organization, is the Accreditation Council for Graduate Medical Education, is the organization that regulates residency and fellowship programs for physicians in the country. On their requirements for internal medicine and internal medicine subspecialty, they stated the following. Each resident should receive instruction in the principles of palliative care. It is desirable that residents participate in hospice and home care. The program must evaluate residents' technical proficiency, communication, humanistic qualities, and professional attitudes and behavior. So, something good is starting to happen. Next slide. We see that palliative care education is improving because of some data that we have from our medical schools. The medical schools in the United States are required to complete an exit questionnaire for all medical students. And the report from the year 2002-2003 was that we had, they surveyed 126 accredited medical schools, and from those, 110 of them, which is about 87%, required instructional hours in palliative care. So that's a good thing. The only problem was that it was a yes or no question, and when they asked about the number of hours, there were 12 hours, but it was highly variable, so you could have 4 hours to 14 hours. Now, if you compare that for 4 years of medical school, that's very, very minimal, but still, it's something. We're going to go to the next slide. And just to give you more interesting numbers, we went and looked at the nursing education, current state of nursing education in palliative care. And what we found was that only 3% of nursing programs in the United States reported having a course dedicated to end-of-life issues in 2002. 3%. When they did focus groups, 40% of the participants of focus groups, which were nursing students, felt that there was a need to increase this content in their curriculum. If you look at nursing textbooks, they offer pretty much none, or very little in the way of end-of-life care. If you look at the chapters, there's not really a chapter in palliative care or end-of-life care in the different nursing textbooks. And also, the nurses report themselves that they wish they had learned more about caring for the dying while they were in school, rather than when they are out practicing and they really have to deal with it. If you go to the next slide, there are special initiatives that we need to consider that will be changing the way that palliative care is being practiced in the country. I have to tell you that I'm very happy to say the VA is the pioneer for the delivery of palliative care and the pioneer for the improvement in palliative care education in the United States. You may know this or may know this already, but the ACGME, which is the institution that regulates fellowships and residencies for medical for physicians, had just submitted the program information for fellowships in the country. So it will be the first time that palliative care will become a subspecialty. But the VA has supported palliative care for the past 10 years already. So we are way ahead of the game. And again, this happened at the VA, and we continue to have great support to deliver palliative care to our veterans. So going back to the slide on special initiatives, we have interesting initiatives such as the OSCE, Objective Structured Clinical Examination. I think most of you are familiar with it, but I just tell you that these are encounters that could be mock encounters using standardized patients or real patients. And what we do is we observe the learner when they are performing a specific task. And we use that a lot in palliative care, especially in our institution. We also have initiatives at the national level. We have the ELNEC, which is End-of-Life Nursing Education Curriculum. We also have it at our institution. One of our interdisciplinary team members is the leader of that. And what this is about is to train nurses in end-of-life care, to give them a overall of what this is about and why it's so very important. We have the same initiative geared towards physician, which is called the EPIC, Education on Palliative and End-of-Life Care. And that is, again, specifically designed for physicians. And we have a version specifically designed for oncologists, which is the EPICO. And those projects are funded by the National Institute of Health. The training is widely available for you to take it, to purchase it, to disseminate it. Other courses that are available to further increase your training and expertise in palliative care include the Palliative Care Educational Practice, which is done at Harvard. It's called the PSEP, and many of us are graduates of that program, and that program specifically addresses how to become a leader in palliative care. And then the last initiative is the CAPC, which is the Center for Advanced Palliative Care, which is led out of Mount Sinai in New York City. They do train programs at different stages. So it could be, just programs that are starting palliative care, or programs that are very mature in their palliative care delivery. So those are things that you could have available. And on the question session, please feel free to ask me anything about these programs. I'll be happy to provide you with that information. Let's go to the next slide. And the reason why I put this slide here is because in many of the VA's palliative care runs out of geriatrics. Not in all of them, but in many of them. In our VA, palliative care runs out of the GREC and out of geriatrics and extended care programs. And I want you to know that geriatrics and palliative care, although are very similar, also have a lot of differences that we need to address. So if you look at the population, part of the table, of course you're going to notice that in geriatrics we deal with older populations, but in palliative care many of our patients happen to be older adults. Quality of life is very important among both specialties. And geriatric syndromes, if you look at the geriatric syndromes part, we refer to delirium, we refer to pain, we refer to falls and weaknesses. And then in palliative care, those syndromes may be represented with all the many symptoms that we have to deal with. Delirium is actually quite common in end-of-life patients, for example. Family is very important. You will be unable to discharge a geriatric patient from the hospital if you don't have any family or caregiver support, and in palliative care it will be the same. They are both subspecialties now. They are both recognized by the American Board of Medical Specialties. And the main difference between geriatrics and palliative care is that functional status is very important in geriatrics. In geriatrics, everything is about function. In palliative care, everything is about comfort and quality of life. So that is the main difference. So that's why geriatrics and palliative care are so close in heart, but also they are different. And I hope you do understand this difference. I wanted to speak with you a little bit about what we have at this VA in San Antonio. We partnered with the University of Texas Health Science Center, and we have a geriatric palliative care program, and we do have two fellowships, the Geriatrics Fellowship and a Palliative Care Interprofessional Fellowship. The clinical services include a consultation service, which we have about 100 plus consults a month of very frail patients. We have an inpatient hospice unit. We have community home hospices that we contract with. We have geriatrics and palliative care clinics, and we do have a component of pediatric palliative care, which is in the community, of course. If you go to the next slide, when it says palliative care educational programs, the educational programs that we run here are, we have an interprofessional palliative care fellowship. We have these fellows do rotate in community hospice settings, and we partnered with our university to bring medical students and to educate residents. If we go to the next figure, which is models of care, a geriatric palliative care team, this is what we base ourselves. Patient and family are the center of our model. And then from now on, we have, if you start from 1 o'clock on your, if you go clockwise and start around 1 o'clock, you go physicians, interdisciplinary trainees, and faculty, research staff, because we do a lot of research to demonstrate that our services actually work and our services are beneficial for our veterans. We have social work, which is indispensable. We are one of our dearest interdisciplinary team members is our social worker. We couldn't live without her. We have chaplains in our team, we have psychologists in our team, and we have communication experts such as Dr. Wittenberg, which help us a lot in improving our communication skills. Now we're going to talk about communication skills, and I'm going to hand this over to Dr. Wittenberg.
Speaking of communication skills, so if we go to the next slide, please. I'd like to begin by addressing 3 of the barriers that exist in terms of end-of-life communication from an interdisciplinary perspective as well. But first we have clinical barriers, and clinical barriers exist in this context in a variety of ways. First is uncertainty, and this is uncertainty predominantly on behalf of the staff. With new research that from the physician's perspective, these are anxiety-laden interactions. They create a lot of anxiety and having the task of going in and disclosing this information to patients. And in fact, our research shows that most physicians would rather not go in and disclose this information. And at the VA in San Antonio, we see a lot of physicians would just rather call in the palliative care consult team to go in and disclose this type of information. Additionally, feelings of failure, particularly on behalf of the healthcare staff who are trying to cure and make this patient better. When it comes to end of life and that is no longer an option, that's incredibly difficult to come to terms with. Coupled with that is the expression of emotion. Many healthcare staff struggle with whether or not to express emotion during these difficult communication interactions. Some research says that it's better if they do. It's better for patients. It's better for families. It shows that we're caring healthcare staff. And other side of this debate shows that it's not professional to express emotion, that it shows weakness, and it's really a coping mechanism on behalf of staff to deal with these kind of communication encounters. Dr. Sanchez-Reilly already explained that there's really a lack of training in terms of how to do this in a clinical setting. And last element of a clinical barrier is a dimension of time. And gosh, I don't have enough time as it is, and now you want me to go in and spend 15 minutes or 30 minutes having this type of communication with a patient that I know is going to take a lot of my time. At this point, we're going to try to go ahead and play a clip from a physician who explains what this time barrier is all about.
And this clip comes from a hospice medical director, so I'm going to play it right now.
When we say about the curative or expected curative role of doctors, I think it's society itself need to impose that on us. And if you go outside of the news, constantly you see the news pounding that, hey, you're the doctor, you should cure this. So this is an expected role that we have to change in the society, saying, well, unfortunately today, not all diseases are curable. Not everybody will come in the suffer. Okay? And I think the second part, what I think happened between physicians and patients, especially about diagnosis, is problem with communication. Is the skill of communicate that diagnosis. I mean, I go to gym clinic, for example, or go to our rheumatology clinic, and I say to somebody, well, doc, what I have? And I say, well, you have a scleroderma. Okay. Now, I'm sure she don't hear anything. She don't know what it is. She don't know what is that prognosis. She don't know anything about it. She would ask any question because now she will sound like a stupid person. Okay, so she will stop right there. And I'm sure like that is very common in daily practice. Okay, you ask me a question and you give me the answer. Yeah, but what imply that answer? If I come and say exactly in her words what is going on, she might be able to understand. That means another 5 minutes explain. And when you work against clock, like this oncology might be, it's kind of, okay, this is what you have. And, instead of sitting down and say, well, we have tried this chemotherapy and it's not working. So, the chances would be that we will switch that and might not respond at all. It's easy to say, it's nothing I can do, bye. Next.
Okay, clip is over.
I'd like to go to the next slide, please. The second type of barrier to these types of interactions are educational barriers, and there's actually one thing that's left off of our slide. The first thing I want to address is hospice, and that many of our patients don't understand what hospice is, what the benefit is, and what it entails. So a large part of this type of interaction includes educating people about hospice. But the second one, which is listed on your slide, is one-way communication, and that is that the predominant approach to educating physicians and healthcare staff about how to handle these interactions is very one-way centered, in that it is teaching a prescribed script on how to facilitate these interactions, and it's not taking into consideration the patient and or the family. We have a clip that we'd like to play for this too, and this is the hospice director who talks about an experience.
And one is communication, and that's called therapeutic silence. When you say the diagnosis and you see that shocked look and you know they're not going to hear another word you say, it's okay to let that silence occur, that therapeutic silence, and offer to come back later and have another session, talk about it later, let them get their thoughts together, let them develop some questions in their mind. So sometimes it is better to let them have that silent period so that you can reschedule another visit with them. But I know what you're saying. Doctors are in such time pressure to see the next one, that you don't have a lot of time. And that's sad, because you just cannot deliver bad news in 5 minutes. You need to have a time block where you do not act rushed in order to deliver bad news effectively.
This particular clip points out the idea of using silence as a communication tool to facilitate these interactions. And currently, our curriculum for physicians as well as nurses do not include the topic of silence and how powerful that can be in these interactions. Next slide, please. The last barrier I want to address is actually a team barrier, and that really is ironic when you think about the team being brought together to provide an interdisciplinary, holistic service to patients and families. But there are barriers to working together as a team. Specifically, when you have different disciplines coming together, each discipline operates and is educated and trained from a particular perspective. I want to play a clip now of a psychologist who talks about how problematic this is for her.
It's difficult to not be able to work with the other disciplines more because of the nature of how they work, of how busy they are, of how hard it is to find time for kind of team building types of experiences, and kind of the misunderstandings of each other and how we work. I can't just drop my patients and move to another rotation. That's unethical according to my discipline's ethics code. I can't do that, and not that that means it's unethical for other disciplines to do that. They're different, they work differently, but it makes it more difficult to work together.
So one of the barriers within and amongst the team is education of what other team members are doing. And we find that even though we have a comprehensive team, that many people don't know what other team members are doing, what they're responsible for, what their area of expertise is, and what they can contribute to the team as well. Well, while all of this sounds rather sad and gloomy, we do have some potential solutions. If you'd like to go to the next slide, please. And Dr. Sanchez-Reilly will begin to discuss this.
So as we identified the different clinical barriers and the fact that different disciplines start from various points of view, if you will, education is our main solution. And definitely, to address team barriers, we do deal with interdisciplinary team meetings. And here in San Antonio, we do have those at least twice a week here, and we get together and we all improve our knowledge and our skills and our attitudes, and we also discuss different things that may or may not be going well in the team. In order for us to deliver good palliative care to our veterans, we need to have a great team. And the team needs to feel that the team members need to feel that they are able to support each other. And that's why interdisciplinary team meetings is so very important. They're not multidisciplinary team meetings, they are interdisciplinary team meetings, which means that every team member is equal and able to provide potential solutions and to communicate without being shut down. There's not really one leader. There is just a lot of people trying to convey a message and to define a core. Something else that is really, really important is the fact that we do have to care for that team, and we need to do self-care activities. We have the one that specifically we do here, we call it a spiritual rounds, and we do that at least once a month. And we bring different difficult cases, and we bring difficult situations that had happened among our team members, or difficult things that had happened within the family even that affect this team and the delivery of palliative care to our veterans. And we talked about those. And we come up with potential solutions, and we also make our team members feel that they are supported and that they do have a core of experts that they can come to and talk to, because palliative care is not an easy discipline to have to deal with. So self-care is absolutely crucial. And then to overcome the educational barriers, we are going to be talking a lot about family meetings, and that's kind of what I like to do the most. You may ask my learners that. And so we're going to go to the next slide. And family meetings or family conferences, whatever you want to call it, they do provide for team environment, and that includes patient and families. And patient and family, again, are the center of our care, the delivery of palliative care, if you will. The good thing is that family meetings are based on communication, and so they're always communicating. We're always communicating between the team, between the patient and families, between the team and the family, between the team and the patient, and so forth. And again, this is necessary for treating the patient's lived body, which is the concept that Dr. Wittenberg introduced before. Excuse me. So what do we know about family meetings? Well, we know that if we involve patients and family at next slide, family meetings background. The importance of involving patients and family members in healthcare teams is very well documented. We know this for many, many studies. We know that if we deal with patients and we deal with family, and we are, as healthcare providers, communicate with them, things are going to go smoother. Also, it has been demonstrated that when we do family meetings, we improve satisfaction with care, coordination with care, and communication among all team members, including patients and family. We're going to go to the next slide, which is, so why are we doing this family meeting? Why would the family members want? And this is actually what they want. There was this study done with many family members after their loved one had died. And they said, well, what do you think could have gone better? And they said, well, I wish that we would have honored my loved one's wishes. And we wanted to be included in the decision-making process. And we definitely wanted some practical help. We wanted support at home, and we wanted to make sure to have transportation, and we wanted medicines and equipment, and we wanted to have personal care needs taken care of. They were very big about having honest information and access to care. They wanted to be listened to. They wanted privacy. And most of all, they wanted to be remembered and contacted after the death. So there are different challenges for family meetings, and sometimes we have difficulty listening. And on the last slide you can see they had difficulty listening, and we have a different perspective. I'm gonna just play the social worker perspective, which talks about the difficulty making decisions. Here's the social worker's perspective.
Because it's so hard when you don't know what the patient wants, and that's the part that really is hard for me. When you see the family member struggling And I know what I would want, but I don't know what he would want. And so that's what's hard. And so that was one of the nice parts too.
And then there are difficult family dynamics that I'm sure you are all familiar with. So if you go to the next slide, we're going to talk about a framework for family meetings. We always, before a family meeting, we do a pre-meeting. We have to treat family meetings very seriously, and we have to do a pre-meeting in which all the team members and members from other or a care team, if you will, they get together and say, this is what we're going to discuss, this is what we're going to talk about. Then we have this concept of bringing the patient into the room. I am not talking about bringing the ICU bed into the waiting room. I am talking about bringing who this patient is into the room. Please, Mrs. Jones, tell me about Mr. Jones. Tell me how good of a father he was. Tell me how what kind of veteran he was. Tell me about his personality, what he did, and so forth. Once you bring the concept of this patient into the room, the family gets relaxed. They immediately know who are they talking about, and then they try to make decisions based in what this patient would have wanted, not in what the family wanted. Excuse me. Once we bring this patient into the room, we could use the spikes model, and the spikes model is a as you are familiar with if you go to the next slide. And I'm going to go very quickly through this, but the SPIKES model stands for S is setting, so you pick a private location. P stands for perception. You find out how the patient viewed the medical situation or the family. I stands for invitation, so you ask whether the patient wants to know or not. K stands for knowledge, and then you deliver a very simple knowledge at a very low level, low literacy level, if you will. E stands for empathy, so you respond to patients' emotions. And then S stands for strategy and summary. Once they know, you include patients in treatment decisions. I tell my learners that the P, which is the second letter from top to bottom, is perception, but it's also patient. So that's when I bring the patient into the room. Now we're going to go to the next slide. And after the SPIKES model, we always comfort and reframe. So we always talked about the plan, and we never leave the patients and families abandoned. And this is the framework that our team uses to go into family meetings and to improve and increase end-of-life communication among our veterans and their families. If you go to the next slide, I don't think we're going to have a lot of time, unfortunately, but we had brought a role play for family meetings, so I'm just going to leave it up to you if you wanted to role play it at your institution. I'm going to read the case, and one of the things that we do with our learners here is we do a lot of role playing, and they get to play the patient's part and the family member's part and the physician's part and the healthcare professionals, other team members' part. And so in that way we understand the roles of everybody, and we can always, it's in a safe environment, and they learn through this. So we're not going to do it this time on the call because it's kind of too late, but I'm just going to read the case, and maybe you could use that later at your own institutions. The exercise was an 85-year-old man with past medical history of diabetes, hypertension, and recently diagnosed metastatic lung cancer. Patient is in the hospital with excruciating pain but alert. His wife and daughter are at the bedside, and they're hoping for a cure. The next slide says, Dr. R, his primary physician and medicine resident, is not very comfortable with delivering bad news. He was never properly trained. His attending physician is not willing to do it either. The family should know by now, he says. Next slide. Patient lives with his wife, and his pension is their only source of income, which is something that we all deal with every day. His daughter has not been involved in their life since he remarried. The palliative care team is called to provide hospice care. This is a typical consultation we get every day. And so I really encourage you to play this case and see what you come up with, and maybe use the family meeting framework that we just talked about. So now I am going to turn this over to Dr. Wittenberg-Lyles, who will be talking a little bit about the skills of communication in family meetings and then the goals of education.
And I will be going at light speed since I do realize it's 1:45 top of the hour. I'm on the slide that says family meetings, a good skill to master, and I want to briefly just talk about two of the benefits to learning about how to master handling communication in a family meeting. The first is family understanding and really understanding your role. Initially, when staff go into these family meetings, their role is to provide information to help the family make decisions regarding the patient's plan of care. But what we see is through the duration of these meetings or over multiple meetings that the staff's role really shifts from information provider to comforter, to helping the family make that decision and comforting them and reassuring them that they're making the right decision for their loved one, particularly in complex family dynamic situations. The second one is facilitating a difficult conversation. That's one of the rewards to this is understanding the context and learning more about who the patient is in order to honor their wishes and in order to care for their lived body, if you will. Next slide, please. So I'm going to talk next about more of interdisciplinary team awareness and interdisciplinary collaboration. Next slide, please. You'll see our mugshots from our team at the VA hospital in San Antonio. Next slide, please. I want to briefly touch on the importance of interdisciplinary care, not just for palliative care and hospice care, but as well for geriatrics care. We know that it has many benefits. In addition to what's seen on the slide, we know that there are improved outcomes regarding the amount of time patients spend at home, satisfaction of patients and families, the control of symptoms, and there's even a cost reduction and reduction in days spent in hospital that are all tied to interdisciplinary team care. So it's very important, and we know that it's increasing in popularity. I want to briefly talk about the several aspects of interdisciplinary collaboration and communication, four in particular. When we have interdisciplinary collaboration, what happens is we have interdependence and flexibility, and that comes from working as a team and also from the blending and flexibility of job responsibilities. So, for example, in a hospice team, we have a case manager who reports on patient cases that they directly oversee, but they also have fluidity in their role as they are sometimes on call, and so they'll provide information which they learned when they were on call. So there's a lot of interdependence and flexibility when you're working on a team. Next slide, please. The second is newly created professional activities, and this is an expansion of the specific team member's role. And these new activities really involve from being in a team environment where maybe you can share information that educates others, maybe on how to treat a particular disease or illness, but it also comes from the creation of new tasks. So you're meeting in the team discloses that, for example, a patient doesn't have a DNR or some other piece of information, which then triggers somebody else in the team to be aware that that needs to be completed. So through the team meetings and through interdisciplinary collaboration, additional tasks emerge. The next slide, please. The third one is a collective ownership of goals. And this is where we have team members sharing responsibilities for making decisions, and they're making it together. This becomes very prevalent when we have issues of what I call special cases, maybe because the patient's family dynamics are very complex. Maybe there's a history of abuse. Maybe it's the age of the patient that makes this a particularly complex case. Or sometimes it's the patient's medical history with their diagnosis. But these require collective ownership of goals. For example, it's really important to make sure that all of this team is communicating the same message when they see the patient and when they see the family. And this type of collective ownership of goals can be discussed so that the same message goes out once the team leaves the team meeting context. Next slide, please. Finally, and what I would consider probably the most important and the one that is least done within teams is the reflective process. And this is taking the time to evaluate the team's outcomes. Particularly in palliative care and more so in hospice care, it's really important to review how the team has conducted a plan of care. And one way that the team is able to do that is to review the patient's status or how the patient's family is coping through the bereavement stage. More importantly, as Dr. Sanchez-Reilly mentioned before, this is quintessential in the team caring for the team. This is when the team is able to share workplace stress, workplace concerns or issues, and really just vent. This is unique to the palliative care team because not a lot of workplace teams have this aspect as part of their collaborative framework. And it's very important that it doesn't go understated. Next slide, please. We want to finally end by saying that the interdisciplinary perspective provides care for the patient's lived body. And that's holistic care, treatment of all pain, whether it's physical, spiritual, emotional, or psychological. That all team members, when you're working from an interdisciplinary-based format, have something to contribute to each aspect, each element of these types of pain that patients have. And our last slide, I guess I will turn it over to our moderator, Michele.
Yes.
Okay.
And at this point, I know that we are running out of time, and because of that, should we be cut off, which I hope we won't, you have their email addresses, so that if you have a question and it hasn't been answered online, you can go ahead and email them and ask them questions. If anyone has a question, you can unmute your phones now. Please turn on your microphone, and someone can ask a question.
Hi, this is Marianne Herbold from the VA Black Hills Healthcare System, and I was wondering if you have, this is mainly an inpatient program, am I correct?
Our program is inpatient and outpatient both.
Oh, okay. So do you have specific clinics set up for various aspects in the outpatient arena then?
We're starting to. We have a palliative care clinic within our GEM clinic, our geriatrics clinic,
Oh, okay.
and we see patients there half a day a week. We're in the process of having a very interdisciplinary palliative care clinic that will include many of our interdisciplinary team members into it, and will be only dedicated to palliative care patients. But ambulatory care in palliative care is much more behind that inpatient care. So we're still working on how can we improve our communication skills and any other skills in our ambulatory setting.
Okay, thank you. That's where we're at too.
Good.
Any other questions? Okay, if there are any that you think of later, you can go ahead and email Dr. Sanchez-Reilly and Wittenberg-Lyles. I'd like to certainly thank them for their presentation today, and thanks to all of you for participating on the call. We really would appreciate it if you take the time to fill out the evaluation forms for the presentation. To evaluate it and to obtain continuing education credit, follow the instructions on either the email or the flyer that announced the call. This audio conference is being rebroadcast Friday, April 25th at 11 a.m. Eastern Time, and the next monthly broadcast will be Thursday, May 29th at 3 p.m. Eastern on evaluation and treatment of hypogonadism in older men, brought to us by the Puget Sound GREC. Thank you again for your participation. We hope you enjoyed the program. Way go.
Thanks, Michele. Do you think you went well?
I think it went great, considering we had medevac in the middle.
Thank you.
Oh, yeah.
So tomorrow you'll replay it from here?
So I will replay it. I'll turn on the phone, dial in.
I guess I'll be on at 10:45.
You'll be on 10:45?
Right.
Yeah, that's probably.
I'm at CTRC.
Yeah. I mean, look at it. It's like we lost it time. But that's okay. They didn't cut us off. That's the good news.
They do cut you off? Like, did
I
they cut you
expected
off?
them to cut us off,
my
but
God.
they didn't. And it's 2:54. Some people had to leave and rudely had their microphone on. There was some guy that's constantly talking the whole time. I wanted to spank him. I think we exhibited tremendous self-control.
Okay.
What a pain in the to the, okay.